Good evening, everybody. It's Dr. Bill Tulo, Medical Director at OCULUS, and I'm really excited tonight to have one of our most exciting speakers. Dr. Cheryl Chapman is going to be talking to us about navigating the challenges in orthokeratology lens design, optimizing the fit, and the outcomes in an ortho-k practice. Before I introduce Dr. Chapman, a little bit of housekeeping. If you have any questions, please put them in the chat so that we can line them up, and when we have time at the end, we'll answer your questions at the end. Dr. Chapman owns a private practice in Gretna, Nebraska. She's the co-founder of Peak Pro, a Techstars 24 physical health Fort Worth company. Dr. Chapman serves as the current president of the American Academy of Orthokeratology and Myopia Control. Her subspecialties include dry eye treatment, specialty contact lenses, and myopia management. Dr. Chapman is a graduate of the University of Houston College of Optometry and an assistant adjunct professor at the University of the Incarnate Word Rosenberg School of Optometry. Without any further ado, Dr. Cheryl Chapman, take it away.
Thank you, Bill. I'm so excited to be here tonight, and I'm just going to jump right in. I appreciate all of the attendees who are here. So I do want to just kind of ask a question as we get started here, so I have an idea of the audience tonight. I would like you to type into your chats if you would consider yourself having no experience with Ortho-k, if you would consider yourself beginner level, intermediate level, or advanced. Go ahead and put those into your chat, and then our team here will be able to read that out and kind of let us know. And then I can kind of tailor the talk a little bit more based on who we have here for our audience tonight. And as you all are putting that in there, I'll just go ahead and kind of start with some of the basics. So one of my favorite slides here is one that just sort of talks about what's happening and Ortho-k in general. What we're trying to do is we're trying to reshape the front surface of the cornea. So I think the prevailing theory is that we get redistribution of those epithelial cells. And that happens not because we're mashing down the cornea, but rather because we are getting a hydraulic push force on that central cornea, and we're getting pull forces on that peripheral cornea. And so you can kind of see that cross-sectional image that we've got there, cross-sectional, the orange being the cornea, the blue being the mold, or the corneal mold, or the corneal Ortho-k lens. And this part of the epithelium here is mid-periphery, and that's the part that's kind of being like pulled over or redistributed over there. Do we have any word on whether our fitters are advanced, intermediate, beginner?
I will hop in here and say that overall we are seeing beginner intermediate.
Okay, wonderful. Thank you. Appreciate that. Okay, so this is just kind of an overview slide. And I know this webinar will be on demand later for you, so you can rewatch this if you want to. So as we walk through things, these are the types of things we're going to be walking through here in the first half of the presentation tonight. So let's get right to it. We're going to talk a little bit about Jessen factor. One of the things that I think is really challenging for new doctors is the variety of verbiage that we use. So almost everything, I feel like almost everything that we're talking about with Ortho-k has 2 or 3 different terms that mean the same thing. So on some of my slides, you will see more than one word or more than one like name for something. And that's so that you can start to familiarize yourselves a little bit with some of the verbiage, so that when you're sitting in a continuing education lecture and a lecturer is talking about this, that, or the other, you can start to build your framework and understand a little bit better. So compression factor is also called the Jessen factor. And every lens that's out there has a little bit different Jessen factor that's built into it. Or if you're working with a software design lens like Wave, which I work with very frequently, you can adjust your own compression factor. And basically what that's talking about is how much overtreatment we're putting onto that lens, because we don't want to just bring a patient down to plano, right? We want to overcorrect them to maybe plus 75 or plus 1 1/4, so that by the end of the day, as their cornea is bouncing back, they're ending up at about 0 so that they're not a little bit myopic by bedtime. We don't want them to be a little bit myopic by bedtime. So when you're looking at the WAVE software, which I have pulled up here, and hopefully you can see my cursor as I move it around here on the screen, here where it says target power, that's where you're able to adjust how much treatment you want. And just because you say you want plus 150 doesn't mean plus 150 is what you're going to get. Because remember, the eye is a living system, so it's going to vary based on that patient's cornea, based on their rigidity, based on the ability for it to actually, move. Everybody's going to reshape a little bit differently, just kind of based on the biology of their eye. But if you want to adjust your own Jessen factor, that where it says target power is where you do it with the WAVE software. Now over here on the side, I have this chart that has listed out diopters. That is referencing the patient's baseline spherical equivalent refractive error. So if a patient comes to me and they want ortho-k and they're a -3, I'm shooting for about a plus 1.4 Jessen factor or compression factor. You will notice that as you get to higher levels of myopia, that we generally want to go a little bit higher. And that's because we don't always get as good of movement or as good of compression with those higher myopes, and sometimes they need a little bit more. So just kind of a little rule of thumb there. It's not hard and fast. Sometimes you have to play around with it a little bit within every patient, but I like to kind of follow along on this. And so I wanted to bring this slide up a little bit bigger so you can see the software a little bit larger. And I'm going to talk about some of the things that you're going to look at on the WAVE template, different things that you can do when you're designing a software lens. So there are some pre-built templates, and you can drop down to see other ones. And you'll get kind of familiar with those, but you can build your own template as well. One of the things that you will always, always, always change is the overall diameter. And you're going to decide what overall diameter you want for your patient based on the patient's visible iris diameter. And I like to say visible iris diameter instead of horizontal visible iris diameter, because not everybody's cornea is completely round. They're usually oval. And so if you were measuring only horizontally, you're going to maybe overestimate, and especially depending on which topographer you have. I find that my Pentacam estimates only horizontal white to white, and I feel like it measures that horizontal bigger than if I use my Medmont, where maybe I will draw, even if I draw horizontal, I feel like I draw that a little bit smaller on Medmont with my caliper, but certainly it's smaller if you do oblique, and certainly it's smaller if you get more vertical. So most corneas that I see, I feel like are not, they have a smaller overall diameter in that vertical meridian than they do in the horizontal meridian. And so I would say a lot of practitioners fit the overall lens diameter to be somewhere around maybe 90 to 97% of the overall diameter. The larger you go, the better centration you're going to have, the more room you have to put a good alignment curve on that lens. I would say if I'm designing from Pentacam, I maybe err more towards the 95% because I know that I'm maybe overestimating a little bit on that overall diameter or on that visual iris diameter. And if I'm fitting based on a Medmont topographer, then I will maybe go closer to 97%. And each practitioner is going to get their own rhythm, and they're going to figure out what works for them. So remember, in Ortho-K, there is not one right answer. You will hear a variety of different rules of thumb or trains of thought on different strategies. And I would say there's more than one right answer in many cases. Okay, so back optic zone diameter is also a parameter that you're often going to adjust. And we will get into talking about that a little bit more a little bit later in the lecture here. The IC diameter is an intermediate curve that is on the WAVE lens design, and you always want the difference between your back optic zone diameter and your IC diameter to be 0.6. So you will see that as 0.6 difference here. So if you change the BOZD, you must also change the IC diameter so that it's always 0.6 different. Central clearance you can adjust, and you're going to see a lot of variety on that too. Some of the software design lenses, you're going to see the recommended central clearance is going to be maybe 10 or 15 microns, whereas on Wave it's 3 microns. Those are just software differences. The reality is that on the eye, your central tear thickness is probably going to be somewhere around 10 to 20 microns. So don't get too caught up on the fact that it looks different in different softwares. You are fairly low on that central clearance. I would say somewhere between 1 and 3 microns when you're putting it into the system here. Freeform versus geometrically symmetric versus RSIM, rotationally symmetric designs. Different trains of thought here. I would say again, there's not one right answer. I don't get into the difference between those very much on this webinar, and I won't because of time constraints. But what I would say is the freeform design is the most specific to every data point, and the rotationally symmetric is more of a spherical lens, so it's much less specific. A lot of waivers fit GSIM all the time. I tend to fit more freeform. Edge lift, you're probably not going to change that too much. Edge angle, you're usually not going to change. Edge thickness, not going to change usually. Center thickness, usually not going to change. We always want to be in axial mode when we're talking about ortho-k lenses. And then these Prism, MB, those are more advanced that are not necessary most of the time. All right, so let's kind of keep moving here. So I said I was going to talk a little bit about back optic zone diameter. We have two different tangential subtractive maps shown here. And on one, you'll see that back optic zone, or that red ring, that peripheral power ring or that red ring, is larger than the other. And I want you to really pay attention to where its location is relative to the pupillary size. So when we're talking about myopia management, we really want our peripheral power curve to be within those pupillary margins, because that's what gives us those spherical aberrations on the retina that help slow progression of nearsightedness, that helps create those stop signals on the retina, stop signals for retinal growth or axial elongation. That also comes into play when we're talking about glare and halos, right? So if we have a smaller back optic zone diameter and a smaller overall treatment zone, we're more likely to get things like glare and halos. So I want you to think about doing a larger back optic zone size for older kids, because they might be driving and we don't want glare and halos while they're driving. We also want to make sure that we're keeping in mind that we need a smaller back optic zone for a younger myope, because a younger myope's eye is growing more aggressively. And so we want to make sure we're getting more spherical aberrations in that 5, 7, 9-year-old myope. By the time that child is turning 15, 16, 18 years old, their eye is not growing as aggressively, so we don't really necessarily need such a small treatment zone for them. I would also advise you to be mindful of doing a larger back optic zone diameter for a higher myope, because they often end up with a smaller treatment zone. Sorry, my screen did something weird there. Our higher myopes often end up with a smaller treatment zone. For example, if I have a 5.8 millimeter treatment zone in a -2 patient versus a -8 patient, I feel like I'm going to end up with a much smaller treatment zone on that -8 patient, even though technically they're both a 5.8 treatment zone. Hopefully that makes sense. So within that, let's talk about some of these things here. Glare and halos. So treatment zone, we kind of already talked about this. Consider the age of your patient. If you've got a patient who's 7, does this much glare bother them? Not necessarily. If you've got a patient who's 16 and a new driver and drives after dark, that can become significant. Also, think about their nighttime sports. Are they playing their games under the lights? Like if they're a 15-year-old baseball player who has a 9 p.m. game, that can impact them. So I wanted to talk about how we modify that back optic zone diameter. The modification tools in the Wave software are really nice. They did an upgrade to their software several years back, made it very intuitive, very user-friendly. And so you have modification tools here, and you'll see this on more screens here. This is not the only time you're going to see this tonight, but basically you just say, hey, I want to change back optic zone diameter. You click on that, and then do you want to increase it or do you want to decrease it? And then you just say by how much, by 0.1, by 0.2, etc. And then it just changes it in the software for you and changes any other parameters that are necessary. So it will change your IC as well, so that it remains at that 0.6 difference. So if you are wanting to reduce glare on a patient, and you're like, okay, well, are they having glare because that lens is decentered, or are they having glare because their back optic zone diameter is just too small relative to their pupillary size? Hopefully this is intuitive. To make it so the patient is experiencing less glare, you simply make that back optic zone diameter larger to get it kind of outside of the pupillary margins. If you have glare due to the lens being decentered, sometimes making the back optic zone larger can help, but sometimes it's okay too. So like we have a little note down here that says maybe it will improve myopia control. There was a good study that was done that showed having coma, higher order aberrations that are put into the eye from having a lot of that treatment zone actually kind of in those pupillary margins like that can improve myopia control. So if your patient is happy, I would say don't get caught up on having that treatment zone decentered a little bit. I would say the doctors who do a lot of ortho-k have a lot of topographies that maybe don't look as pretty as they would like, but the patient is delighted because their vision is good, they're comfortable with it, and sometimes you end up with better myopia control because of those off-axis optics. So let's talk a little bit about what we do with a lens that is superiorly decentered. So remember that we will have that smiley face topography, meaning that the treatment zone is centered high. And so like if this were the patient's nose, they have a little smiley face down here. That's kind of how it gets its name. And we know that if the lens is superiorly decentered, that it has that it's too flat. And so that means that we don't have enough sagittal depth that causes the lens to ride high. So how do we troubleshoot that? We need to increase the sagittal depth, or you can steepen that alignment curve to do that, or you can increase the overall diameter to do that. So let's kind of look at that in the software. So this is kind of your first look at the software here tonight. Here's our modification area down here. If you hit that modification tool, that's where you will get to see a lot of those little tools pop up, and we'll show you more of that here in a moment. But I want to orient you to what we're looking at right here. That is our simulated tear film. So this is just a simulation. This may not be exactly how it ends up looking on the patient's eye, but I would say it's pretty good, pretty close. So overall, this is where our reverse curve is here. And that's where we get that pull force, right? So that our epithelium from the central cornea is moving this direction. Here we're getting our push force in the center. And when we're looking at this part right here, that's our alignment curve. We call it the alignment curve because it's what is aligning onto the cornea, and that affects our centration. So frequently, I would say if I have decentration of a lens, one of the first things I'm looking at is adjusting my alignment curve, either flattening it or steepening it. So when we go into that modification area, again, we see these. And if we want to change that alignment curve because our lens was too flat and we want to steepen it, you can simply hit alignment zone. And I'm going to see if this whoops, hold on. So we hit alignment zone. Yes, I want to increase my sagittal depth or my sag. And by how much? I can tell it how much. I can tell it I want to do it by 5 microns, 10 microns, 20 microns. I would say making any change less than 10 microns is like making no change at all. I would say you always want to do at least 10 microns, maybe 15 or 20. So within that range is reasonable. And then if you're looking here, usually you're going to be making a change in all mode, but there are cases where we don't want to change the lens all the way around. Sometimes we just want to change it on one meridian. And so that's where that half and that 1/4 mode come in. And I will work through some troubleshooting on that here a little bit later in the presentation tonight. All right, so if we have inferior decentration, this is like the opposite problem, right? So they have a frowny face. So now we're thinking about this top part of that peripheral power curve being kind of like down in the center area of our topographer or a topography. That has too much sagittal depth. It's too steep. The lens is riding low. So how do we troubleshoot that? Again, you just go to your modification tool, you hit that alignment, and you select that you want to decrease the sag. And again, how much? Often you'll decrease it by at a minimum 10, maybe 15 or 20, depending on how overly tight you felt like that lens was. Another modification that technically can be right is to just change your overall diameter. Remember, when you decrease the overall diameter of a lens, it does decrease the overall sagittal depth. Although I would only do that if I went back and looked at my visual iris diameter and realized maybe I didn't measure it right. If I feel like my overall diameter is adequate, I will do the alignment curve 95% of the time as my modification. So I would say that most orthokeratologists are more frustrated by lateral decentration than they are by superior or inferior decentration, because I feel like it's a lot harder to fix. One of the reasons it's a lot harder to fix is because it's more impacted by the interaction of the eyelid with that lens in the closed eye environment, particularly if you're fitting a lot of kids of Asian heritage, because they tend to have that stiffer upper tarsus and it interacts with that lens more. So sometimes it's a losing battle. Sometimes it's very, very difficult to adjust that decentration that is lateral. But in general, some rule of thumbs to follow: if you have nasal decentration of that lens, then you'll find that either it's those tight lids pushing it, or perhaps that lens is a little too tight or too steep or has too much sagittal depth. And so you may, in fact, want to flatten that lens and see if that helps. So again, most of the time I'm adjusting the alignment curve in this case. It can be nasal, it can be temporal. If it's temporal decentration, it's often because the lens is too loose. So you might want to come back and watch this part of the webinar again, or you can go online to the Waves Troubleshooting. Some of these pictures are pulled straight out of their very succinct little troubleshooting fit guide that they have available to practitioners. I keep this next to my desk in a couple laminated sheets so I can reference it whenever for myself or when I'm chatting with fourth year externs to help teach them some of these tools. All right, so let's go on to central island. Central island is really important to think about whether or not it's a real central island, because if you have a pentacam, you know that you're using Scheimpflug tonometry that helps look at your cornea, your true corneal shape. But if you're using a Placido-based topographer, you're actually measuring the tear film. And if a patient has central SPK, which sometimes they do with Ortho-k, especially if it's after their first night of wear, that central SPK will make it look like you have a central island. So be very sure that if you are seeing a central island on topography, that it is a true central island and not a, quote, false central island. A true central island is caused by the lens being too steep, and that will actually cause your hydraulic forces to go the wrong direction. Instead of flattening that central cornea, it will actually pull more epithelium towards that central cornea, causing that central cornea to sort of pop up. And that will definitely make the patient's vision worse rather than better. So if you're not really sure if it's a true central island, let's say that patient was a -2 to begin with, and they come back after their first night of wear, and now they're a -3, and they look like a central island. Well, you have done the opposite of what you've intended. You have steepened their central cornea, so you are making them more myopic rather than less myopic. If they come back and it looks like a central island, but they were a -2 baseline, and now you're getting a -0.5, that's not a central island because you have flattened that central cornea. All right, troubleshooting that central island. So we were too steep, right? So we want to decrease that sagittal depth, and you can do that again by flattening that alignment curve or decreasing the overall diameter. Again, most of the time it's flattening the alignment curve. So what you'll find as you're kind of going through some of this troubleshooting is there's only so much you're gonna do, right? Like fitting Ortho-k is not so mysterious once you break it down with a really simple software like this. I wanted to kind of give you an opportunity to see what it looks like here. When we're looking at this cross-sectional view of that tear film layer, remember that alignment curve here? In this one, it looks like it is aligned perfectly with the peripheral cornea. Here is what it looks like after you flatten it. It kind of flares up at the edges, and we have a little bit more tear film underneath that alignment curve. And depending on what topographer you use, you may find that so know your topographer, right? You may find that your lenses are all fitting a little bit steep. So you might adjust your fitting technique to automatically flatten the alignment curve on your first lens design by about 10 microns on all of your patients. And once you kind of get to know your topographer and get to know some of those little things that help you be a better fitter, that will increase your first lens fit success rate. Other tools for decreasing the sagittal depth can be also to flatten the reverse curve rather than flattening the alignment curve. Flattening the reverse curve will do it as well. And you'll see that reverse zone part of the tool there. I have done that on a few occasions. I've had it work sometimes, and I've had it work not quite as well other times. And so I am, we're always learning, right? So I feel like I have still so much to learn about fitting Ortho-k, and that is one that I want to get a little bit better at before I can really feel like I can talk like an expert about those reverse zone changes, because for me sometimes it's worked well and sometimes I undid that and went back to changing the alignment zone. If we have again too little sagittal depth and we want to steepen the lens overall, you can also steepen that reverse curve. All right, so I want to spend a little bit of time talking about how to deal with residual cylinder, because I get this question a lot. This is one of my favorite things about Wave software, because I've worked with multiple different software design lenses because I like to just try different stuff out and kind of see what sticks. And I think I've gravitated towards Wave as being my favorite over anything else because of what I can do with residual cylinder. A lot of my patients who are in Ortho-k have gone that route because they're not good candidates for soft myopia management contact lenses because of the amount of cylinder they have. So I'm not afraid of a high cyl case. I'm not afraid of treating 3 or 4 diopters of cylinder. And the reason is because I know I can handle it with Wave. So what do we do with it? If I have a patient who I'm finding they have leftover residual cylinder, then I know that I can create an oval treatment zone. So if you look closely at this, you'll see it's not round, it is oval, it is egg-shaped. And I can create that oval treatment zone. I can also play with that Jessen factor, that topographic demand, that compression factor. I can play with that in only one meridian. I can change it in just the vertical. Remember that half mode and that quarter mode, or I can change it in just the horizontal. So let's look at how that looks. Now, if you have with the rule astigmatism. And remember, with the rule astigmatism is a little bit easier in general for us to work with when we're doing ortho-k fits. Then you want your oval to be longer on the horizontal meridian and shorter on the steeper meridian. I'm sorry, steeper on the vertical meridian. And I created this little like pictogram here or whatever, so you can just kind of see with the rule, oval this way. If their cylinder happens to be a gill, you want the oval to be longer on that up and down. And I think this kind of walks us through. So you can look at the fluorescein map there, and do you see that little hash, that little white hash right there? That tells you what meridian you're working in. And notice that we have it in quarter mode here instead of all mode. So when I have my hash here, that is my nasal part of my lens that I'm working on, working over here in quarter mode. So any changes that I make are only going to change that nasal part of the lens. And you can adjust how big of changes you're making. You can be 1 times change, which is the smallest increments. You can go 2 times, 4 times, or 8 times. And when you click on any of these little nodes, it kind of pops up like that with your little arrows. And you'll see that after we make that change, oh, I'm sorry. You'll see now I have it in a different meridian here. So instead of in nasal, now I'm showing you what it looks like when I'm in the inferior meridian. Again, the white hash is there, inferior is here, and we can change it here. So remember how the depth of this tear film looked on our previous slide. I'm going to go back to that. It wasn't as deep. And now we're on that vertical meridian. It's much deeper. And you'll see that that power demand changes as well. We'll go back here. See, it was 1.46 there. Now going back here, you see it's more. And so by getting a deeper reverse curve, we're moving more tissue. Our peripheral power curve should have more power to it there. And that is why that on the tangential map, the peripheral power curve in the vertical meridian is going to be a deeper, more robust red. Okay, and so you can, if you're like, if you've already made an oval treatment zone and you're like, wow, but I still have some residual still, you can increase that demand by just clicking up and down on those regions as well. I want to make sure I explained correctly too. Let me go back here a moment. Okay, so one other thing I want to point out here that I did not point out properly the first time through, look at your optic zone diameter here is 6.7, and this is a with the rule patient. So we're, oh, I'm sorry, this is in against the rule patient. So I am a little bit shorter in my horizontal meridian. I said that backwards. See, this is hard even for somebody who does it all the time. So here I'm in my vertical meridian. Here I'm shorter. My optic zone diameter is 6.3. And here in my horizontal meridian, it's 6.7. And I do want to point out again, the difference here between the optic zone and the IC is 0.6 difference. And here it's 0.6 difference. So anytime you're changing this, you want to do it when you're, I would say you want to do it when you're going to be able to do it without interruption to make sure that you change both your inferior and your superior. And you want to change your optic zone diameter as well as your IC so that it's always that 0.6 difference. And when you're changing that, it is going to change your power demand a little bit, but if you want to change it even further than just making it oval, then that's when you can go in and do the up and down here with your power demand. All right, so one other thing I want to talk about, I've seen this posted, this question posted online. Sometimes people ask about this double red ring that they're seeing, or they feel like they've got like two peripheral power curves going on. And I've seen some people throw some different answers out there. But in my training, what I learned and what I have found to be the case with regards to how it responds to troubleshooting is that generally means that your lens is too tight. So even if that lens looks centered, like it does in this case, if you're seeing this and this, that's an indicator that your lens is just fitting too tight. And I would say I'm not a big fan of that because I don't think it's good for the cornea. In the instances where I've seen this on my own patients, they tend to have a lot of SPK and they tend to have a lot of lens binding. And so the troubleshoot for that is very, very simple. You can just flatten your lens by flattening that alignment curve. And usually the centration stays like really pretty nice. But yeah, it's an interesting conundrum that people run up against. And I've seen a variety of different explanations for that, but my belief is that it means it is just too tight. All right, so if I've got a patient comes in and let's say they're a -3 and I thought I was gonna, let's say I thought I was gonna make them like a Justin factor where they would come back the next morning and they're like a +1, or after a month of treatment, I thought they'd be about a +1, +1.25. But they're still undertreated. Maybe they come back and they're like a -50. You're not always going to get what you predict you're going to get because everybody's cornea is a little bit different. And so you just need to add a little bit more treatment to that lens. Or they come back and they're like way more plus than you thought they were going to be. Like they responded so well to treatment. They've got such a flexible cornea and you need to back off a little bit. Or let's say you've had a patient in Ortho-K for a while and you feel like you're getting pretty good control, but over time they've had a little bit of creep in their axial length. And now all of a sudden they're just not getting as clear a vision by the end of the day. And you suspect it's probably because they've progressed slightly. And we see that, like we want everybody to stop growing. We want to hold it 100%, but we know that we're not always getting 100% control and there will be some creep of axial length. So if you want to increase your treatment, I love this part of the software because I don't have to really think about curvature of radius or how many diopters equates to how much millimeters change on that back optic zone diameter, because they have done it where they have it in diopters. So if I want to increase my treatment, I would just flatten that lens. If I want to decrease my treatment, I steepen that lens, and I can tell the software if I want to do it by a quarter diopter or a half diopter or 0.75 diopters, and then you just hit apply and it does it for you. So that's a pretty nice piece of the software. Other ways to deal with undercorrection are to adjust the reverse zone. So here's a nice little troubleshoot that is, again, put out by Wave Software, and it depends on how much undercorrection there is. So if you have quite a bit of undercorrection, you're maybe going to play with that reverse zone. But if you have less undercorrection, like maybe you only need to change it by a quarter or 0.5, then just doing the base curve, I would say, is the better choice. And if you have overtreatment, again, it's kind of the exact same thing in reverse. All right, so wearing time considerations. A lot of people already are aware that if a patient's not wearing the lenses long enough, then you're not going to get enough treatment, right? So I had a daughter who did great with Ortho-K up until she started high school, at which time her studies became more intense. She would stay up later studying and would often fall asleep studying and would not put her Ortho-K in until she woke up at like 2 in the morning. Is like, oh my goodness, I have to put in my Ortho-K. But then she would take it out at like 5:30 or 6 a.m. So she was only getting about 4 hours and it just was not enough for her. And everybody knows that. That makes sense. But also, I've had patients that come in for a follow-up visit during their summer holiday or their school holidays, and all of a sudden their vision's just not as good. And when you start questioning them about their wear time, it's like, well, you know, he put them in at about 11, but then he slept in until about 1 o'clock today. And like, oh my gosh, like this patient just got 12, 13, 14 hours of wear. And these teenagers do that. They will just like lounge in bed for hours and hours and hours. And yeah, that will screw up their clarity of vision as well. So I will just tell mom, you know, that's just too much of a good thing. So don't overwear them. So other considerations, one of those things is loss of treatment over time. When lenses get old, plastic warps as it gets old. So we know that when we start to reach that 10, 11, 12-month mark, we will often see that those lenses maybe aren't creating those great hydraulic forces that they were in the beginning. And as the hydraulic forces kind of fall away, then we don't get as clean of corneal molding as we did in the beginning, and then the sharpness of vision starts to become reduced. That can happen due to lens warpage. That can happen due to scratches on the lenses. That can happen due to deposits on the lenses. Sometimes I will just have the patient do a ProGent treatment, and sometimes that'll get them back on track until they're closer to that 1 year mark. So lens age, warpage, deposits, lens handling, if they're really rough with them, then they're going to warp more easily, and then just shrinkage of plastic over time. All right, and sometimes it's not a problem with the lens. Sometimes they've simply progressed in their myopia. If you have axial length instrumentation, that will give you a very clear answer as to whether or not progression is part of the problem. All right, so other things that can happen. If your lens is not fitting properly, it can cause an abrasion on that central cornea. If your lens is too steep, you can actually get a lot of SPK or even abrasions, more where the alignment curve is landing in the mid-peripheral or peripheral cornea. And sometimes if your lens is too steep, the tears are going to stagnate. You'll get lack of oxygen, and that can be bad for the cornea. So we talked about that double red ring. These are my concerns and what I have seen with like peripheral, like significant peripheral SPK when we're too tight like that. Also, I want you to think about keratoconus. If a patient has been in ortho-k for a while and they are an emerging cone, you are not going to know unless you're measuring their back surface topography. If you have Pentacam, you're golden because you will be able to get that back surface data. If you are on a placido-based topography, you're not going to quite know what's going on the back surface. But if you have a patient who's been doing really well in ortho-k for a while, and then all of a sudden they're not doing well anymore, I want you to think about potentially washing them out and just making sure there's not something else going on. Because certainly somebody who's an emerging cone can start to have more issues. So I think we have some time for questions.
Fantastic, Cheryl. In fact, you've answered many of the questions that have come in, but I'm going to ask you a few that maybe we can just go into more detail.
Great.
Can you talk a little bit about the challenge of doing ortho-k on low myopes, like under a diopter?
Yes, that's a really interesting question, Bill. So the question is, what do we do when we're considering ortho-k on a low myope, like a -1 diopter or less? All right, so if I have a low myope, they're pretty easy to mold, but when you look at their difference map on topography, you're going to be very underwhelmed by the peripheral power curve that you get. And that's because you're not moving very much corneal tissue. And so you might think, wow, it's not working. We're not getting good hydraulic forces. No, that's not necessarily the case. You might get them to where they have fantastic vision and you have flattened the cornea as much as the cornea needs to be flattened. However, if you don't create a robust power ring, you're perhaps not getting as much spherical aberration to enter the eye as you need to in order to have good myopia control. So if you've got an older patient and you're less concerned about fast progressing myopia, then you don't have to worry as much about that peripheral power curve being robust because you don't need those strong spherical aberrations. If you have, though, a young child, a 5-year-old, 6 or 7-year-old, somebody who's high risk, and their eye is already too long, and you're seeing that they're a -1 and this parent really wants to do ortho-k, then you can create a more robust power ring by playing around with a software design lens. You're not going to do it with an off-the-shelf lens, but you can do it with a software design lens where you're very intentional about having the right amount of compression factor so that you place them at a good target power for their vision, but also getting a deeper reverse curve and a little bit more tissue movement to that mid-periphery so that you get that nice, robust red power ring. Is that clear, Bill?
Exactly clear, yeah. And the other consideration, would you consider sometimes on these low myopes that maybe adding atropine as adjunct therapy along with the ortho-k just to get more control, or do you feel you can design a lens for that -75 myope with a good enough return zone most times without having to do that?
Great question. So I think the studies are really strong that dual therapy can be very synergistic, and you can get improved results on somebody who's still progressing on ortho-k, but I would never do that out of the gate. I would
Mhm.
always just do one therapy first, and it's going to vary. Some kids just change more than other kids. And, and part of it's going to be their visual hygiene habits. Like, are they on screens more? Is their working distance really too close? Are they getting enough outdoor time? What is their parental myopia, their genetic risk factors? Things like that are going to play a factor as well. But I would start with just ortho-k. I would see them back again and, I would measure their axial length again every 3 months. And if I'm not satisfied with the results that I'm getting, then I will, in fact, go ahead and add atropine. I like to start when it's dual therapy. I like to start low with 0.01% atropine, even though I never start with that if I'm using atropine as their only therapy. But I think in cases like this where you're doing dual therapy, it's okay to start low like that based on the studies.
Excellent. Can you comment a little bit about the challenge with teenagers who can't get 7 or 8 hours of sleep because of their activities and study demands and activities and things that happen? When talk about
And activities
they,
and
yeah.
activities.
So would you ever
Uh,
recommend like putting the lenses in before they go to sleep, and tell us about the challenges of that daytime wear?
so the way I fit ortho-k and the way many doctors fit ortho-k is we are designing a lens to be worn in a closed eye environment. And when you have that patient sitting there with the lens on their eye and their eye is open and they're blinking, that's really hard. I do not advise that. I have not, and I bet there are doctors who would disagree with me, and that's okay. We already said that there's more than one way to do things and there's more than one right answer. But for me, I feel like it is not a good path to go down because when they're open and they're blinking their eyes, like you're just gonna see a lot of different stuff happening. You're gonna have a lot of comfort complaints. You're gonna have more eye rubbing. You're gonna have just a really hard battle with that patient who really doesn't like it. And then I think you're going to run into cases where they're telling their parents they're wearing it when they're not wearing it, and it's just a hot mess in my mind.
Excellent. You talked nicely about residual astigmatism since it's such a common issue, and there's all kinds of residual astigmatism. Sometimes it's because of decentration, sometimes it's because incomplete return zones, and other times it's just because there is residual astigmatism with any spherical hard lens on a patient's cornea when the refractive astigmatism doesn't match the corneal astigmatism. Can you talk a little bit about, other than oval optic zones, like if you have an incomplete return zone, um, do you have any other techniques or methods to try to battle that resultant astigmatism that can be found from that?
Great question. So incomplete return zones, I think, are daunting, can be a little daunting sometimes. But again, let's look at the robustness of what WAVE can do, because we can switch it down to those, like changing it just in that quarter area. So we can change just one quadrant. And yes, and thank you for saying I did a nice job, because I always have to think really hard whenever I'm doing a residual astigmatism troubleshooting. And like I said, I like to make sure I'm not interrupted, because I really have to concentrate to make sure I change everything exactly the way that I want to change it before I submit that order. But yeah, you can play around with it. You can change just one quadrant to try and adjust the depth of the return zone. You can change only the topographic demand in the return zone in that one quadrant to try and like get more of the corneal cells to kind of pull that direction. You don't have to do it both superior and inferior, for example. You could do it just inferior if you wanted to. And I think that technique is kind of fun to play around with, because when we have the simulated tear film, we get to see what's supposed to happen. And I would encourage anybody who's like doing it for the first time to, talk to the consultants at WAVE, because they're actually like super knowledgeable on it, and they can help guide you through it to make sure you're going the right direction if you're not sure which direction to go. And then you just take notes, and then you refer back to your notes the next time you need to do it. And then again, you just submit that order, you bring that, lens in, put it on the patient, see the patient back, see if it did what you thought it was going to do. And that's part of how we learn.
It's funny you mentioned non-interrupted. I remember we talked a couple of years back at one of the vision design meetings, and you told me about the oval optic zones and how they work. And I couldn't wait to go back and try it. And the first one that I did exactly backwards, and I doubled the astigmatism. Because I probably was interrupted, and so now I printed out your notes, and they're right on the side of my ordering computer. So when I am doing that, I make sure I don't do it between patients. I do it at the end of the day when I'm not interrupted, and I make sure I take a peek at those notes, because I can talk myself into it the opposite way also if I'm not paying close attention to what I'm doing. So I think your point of don't get interrupted when you're doing something that detailed. It's more complicated than just changing a simple parameter. Excellent. Another minor detail question. Can you talk a little bit about dimple veil in return zones, especially on high myopes, and how concerned are you, and when do you do something about it?
Yeah, okay. So I think the general consensus is that dimple veiling is not a big deal. However, I think you're going to have some people who believe that perhaps dimple veiling can be a bit of a big deal. I think, and tell me if you agree on this, Bill, because you're an expert in this space as well. I think dimple veiling is often an indication that the tears are static, that we're not getting good tear exchange, and that it indicates that things are a little bit too steep. So even though dimple veiling in and of itself is not hurting the patient, it's probably an indication that the overall lens design is too steep, which can have detrimental effects on that patient's cornea over time. So I'm going to probably flatten that lens, probably by flattening the alignment curve, or if I'm concerned about that reverse curve, I might decrease the sagittal depth in that reverse curve as a possible troubleshoot, which of course we can do very, very easily with that with that WAVE software. And again, remember our tear profile on a myopic patient, on a high myope, our reverse curve is quite a bit deeper in them. And so, yeah, we have plenty of room to bring that reverse curve down if we need to.
So yeah, I totally agree. In fact, I've noticed that if I have that patient coming in the morning with the lenses still in their eyes, and they have dimple veil that I already know, number one, their complaints are always my vision is blurry for the first half hour, an hour, then it's fine. And then I look at the lens when it's still in their eye in the morning, and it is tight. And so doing exactly what you described seems to work for me also. The trick is not to take the demand and the return down so low that now you lose the myopic. I mean, then your ejection factor goes down and everything goes down with it. So you have to compensate for that
Yeah.
too.
Do you,
Excellent.
Bill, do you generally change the reverse curve, or do you generally just do it with the alignment curve?
I actually often will do with both, and I'll use one to counteract the other. I find when
Very
I
good.
do it only with the return curve, I fix the dimple bell and I cause a different problem. So I kind of try to do two things, and sometimes it's the alignment zone and the return zone, sometimes the return zone and the optic zone. So I'll do various things. Sometimes I'll push the dimple veil out of the pupil area so that they just don't see it. It really depends on how high the myopia is and what I'm trying to achieve. But I just notice it's often when the patients complain of morning blur for the first hour or two. It's often because if they come in at 7 o'clock at night, I'm not going to see the dimple veil. I'm not going to see any. It's going to look fine. So I have those patients who complain of
Yeah.
morning blur come in the morning with the lens still in their eyes, and then I often will see exactly what it is.
That's interesting. I've never thought about that before. You know, it used to be that there was a strong recommendation for the protocol to be to have the patient come back with the lenses on their eyes for a one-day follow-up. But I think the more common practice now is to have the patient take the lenses out when they wake up and then come in for their follow-up visit. But you've kind of adopted a hybrid strategy of, if they have this problem, then I will have them come in wearing their lens in the morning. And I think that's really smart.
Yeah, I think in the old days with the old lens designs, we had so many problems with adhesion that I would always do a one
Hmm.
day follow up just with a new lens just to make sure that I don't have a kid with an adhered lens that could potentially cause harm. I think the designs now are so good, and I see that so infrequently that I'm only concerned when there are symptoms early in the morning. But again, the younger the child, the more cautious I become. I want to say a big thank you for you that you are the first person in a long time, or that I can even remember, that brought up the screening for keratoconus before fitting kids in orthokeratology. I just saw last week my second kid that was referred to me wearing ortho-k lenses. It came in that turned out to have keratoconus that was being disguised by the ortho-k. And it was never really screened for properly. And it's the second one I've seen now in about 2 years. And I think your recommendation of just routinely doing that before you start to fit is really important. I think you can't tell sometimes on a 6, 7, 8-year-old, and sometimes the keratoconus hasn't started yet. And the ortho-k does a really great job of altering the front surface, and then all the algorithms for finding keratoconus become defeated. And now you're going to find it eventually, but eventually sometimes is after they've lost best corrected vision. So your comment about, if the lens is just not working the way it should, and you're having trouble, you're on your third lens, and there's not any reason really why this is happening, a washout and a check is really, really advised. So I thank you for saying that. I think it's an underutilized thing, and the more people talk about it, I think the better our kids and the safer our kids will be. So that is all the questions for tonight. I want to thank everyone for attending. We had great attendance tonight. If there's any additional questions, I'm sure we'll be happy to send email responses out. But Cheryl, thank you so much for sharing your expertise. I can't tell you how much I always learn when you talk about this topic. So thank you so much. And everybody have a great evening.
Thank you for having me.